Approval. Second.
All in favor?
Aye.
Anyone opposed? Okay, I had one question from those minutes. What's the crisis continuum of care?
The crisis continuum of care and the crisis now model of care that we have been trying to implement in this community, I think is ripe for a whole nother discussion and agenda item for how we going to sustain that here in the city of Billings, because right now, as of October 24th, there is no ongoing mobile crisis work being done in the city because of some hiccups. And so we need to work through those. We have some work to do to develop a transition plan. That work was being done by Rimrock in concert with the fire department and EMS. And we have had some transition occur with the program. We've had transition that's upcoming with Substance Abuse Connect. And so RiverStone Health is going to be taking more of a leadership position, working with the city, working with the county, working with other partners across the region to try to sustain that crisis system and continuum.
Excuse me. So this is crisis, individuals that are in crisis or a big
Behavioral
crisis?
health crisis. Behavioral health crisis.
Okay, thank you.
Good. Okay, John, you're up.
I make a motion that folks get up and get their breakfast now that it's ready. Do my report. Go ahead. Please.
Yeah, it's hard to persuade you.
You can listen and get breakfast at the same time. Go ahead.
You're not gonna get your breakfast first.
What's that?
You got your catch.
Oh, he doesn't eat till after.
Go ahead. Go ahead. I'll eat after my report. So just first and foremost, we've got a little bit of public engagement after the Billings Gazette featured Dr. Saunders in an article highlighting the importance of safe storage of firearms. This is a community issue. Billings Police Department reported that over 200 weapons were stolen from vehicles in 2023. We have an issue that continues to be a leading cause of death for kids and teenagers, almost 107,000 deaths among children, and particularly 90% of the guns involved in the deaths were unlocked and loaded, not stored safely. We have a brand new industry in this community, United Defense Technologies, bringing a new RFID lockbox to market for safe firearm storage. We celebrated that fact, and that whole company was founded because of an accidental gun injury. This is not an issue that we are fighting because we're trying to take away individual freedoms. This is not a infringement on Second Amendment protection. This is about keeping our community safe. 90%, I said, were unlocked and loaded. 85% of the incidents occurred in the home. 74% of the incidents involved handguns. 61% were left unsecured in the bedroom, in a closet, or in a vehicle. And 45% were owned by a parent or guardian. It's also a suicide prevention tactic. We have the highest rate of death by suicide in the United States. Montana is number one. That is not something to be proud of. And 60% of suicides in this community are completed with a firearm. But we know that if it is stored safely, if it is unloaded, if it is potentially locked or safely stored, that has an opportunity to create a pause, to prevent a suicide, to allow somebody to ask for help. That is why we are taking this initiative seriously, offering gun locks to folks in this community. It is about safe storage and responsible gun ownership. When you come here and you get a lock, Some of you around the table have received them already. You don't have to give any identifying information. You don't have to tell us how many guns you have. You don't have to tell us what type of gun you have. All we care is that you're being a responsible gun owner, you're keeping it safely stored, and you're preventing that next preventable death.
Are there any criminal penalties for unsafe storage?
It's a good question.
I don't believe there are in Montana.
No, I don't think so, but I was thinking there should be.
So we were thrilled to get the $300,000 grant from the Montana Healthcare Foundation. So we're going to get $300,000 over the next 3 years, and that'll support our startup in new senior high school-based health center. So we're planning to open that senior high school-based health center shortly next month. We'll be doing a slow open, a cold open, and then we'll have a big grand opening and open house and share more about that. I'm going to go to the school board meeting on the 5th of next month, present to the planning and development committee on the benefits of school-based health centers, what we do versus what we don't do, and how we interplay to create a better school environment and a better health environment for our kids. Our Joliet clinic, we've now signed a lease, and we'll be moving in at the end of the month to a facility next to, right on Highway 212, next to the 212 Grill. We'll be in that space, hopefully temporarily. We're calling it an alternative location for now, that we've had to move out of the community center. And we continue to work with Joliet to find a new permanent location to design and build a clinic there in Joliet. Outreach to Medicaid patients continues. We've had a small fluctuation. Last month, I reported a larger number. We actually saw only a decrease of 69 attributed Medicaid patients between August and September. We identified a reporting error between our numbers and DPHHS's numbers. So at least it wasn't that big of a dip, but you can see it's still fluctuating up and down between 4,000 and 4,100 attributed Medicaid patients. So,
John, you mentioned that 430 to 500 to uninsured patients. Of those, how many are eligible for Medicaid? Do you know when generally all eligible?
we're seeing a lot of different things. Some of them are eligible. Some of them are shifting over to the marketplace. It's kind of ebbs and flows. Do you have a percentage, Eric?
I don't. We are reporting. So our care managers and Lauren, one of our senior directors over in the clinic, are doing monthly tallies of how many people they are working on for issues related to insurance. So we're tracking it. I just don't have it with me today. And there's too many numbers on there to try and quote you something. It'll just.
Available for most of them, or some of them just completely out of luck?
Well, there are some people who in the period of, continuing enrollment became ineligible and aren't legitimately eligible now. I don't think that's the majority of the people. Most of what I'm seeing are folks that we have assisted in applying, and they're at some point in the process of having their application reviewed and approved or denied. So I just don't have those specific numbers here today.
Thanks.
Yeah.
Yeah, and as you can see on the next page, the number of applicants rose dramatically at the beginning of this process from April of last year to November of last year. You can see the peak there of about 9,400 applicants, and that is just Yellowstone County. That peak is the Yellowstone County data to our attributed patients. And so that's a huge number of folks that have applied. So that's obviously overwhelming the staff at BPHHS, and we're giving them the grace to work through the applications and the application process. But it has resulted in some of those backlogs so that we see folks that are up there in limbo waiting to get their benefit.
Does Medicaid or PPHHS report transparently how many applications are pending and how far behind they are in their processing, or is that not a number that's on their dashboard or something?
Nothing that's out there on the public dashboard that this data's come from. All we can tell is that there were 9,360 applications completed in November, but we can't tell how many of those are still pending, how many have been processed.
So I was talking to a legislator yesterday and this came up, and her comment to me was that, well, they're being told that they're caught up. So DPHHS is telling the community and legislators that everything's fine. And I said, I don't think so. But
So we're working on cleaning up our data. So, and we've got a meeting scheduled with the director and DPHHS staff next in December, once we get into the session. And that we're going to share some of the data of what are we seeing on the ground and how is it impacting us realistically, so that we can have that two-way conversation with the department and with ourselves. So more on that. Speaking of Medicaid, we had a great conversation a couple of weeks ago now. We had a fireside chat with Rep. Ed Buttry. Came down from Great Falls to talk Medicaid, talk about the benefits, the economic benefits. Some of the numbers that are included in here. Over half of Montana businesses have at least one employee on Medicaid. Saves the state $28 million in budget savings, nearly 60% decrease in uncompensated care costs to our hospitals. And not a single critical access hospital in the state of Montana has closed as a result. When there's an epidemic of critical access hospitals closing across the country, we've been able to make that happen here in our state. And so Ed came to town. We talked about some of the rumors and mistruths, misinformation that was shared during an interim committee hearing. We were able to tackle that head on and work through questions about Medicaid. So thank Ed for coming to Billings and sharing that information with business leaders.
They presented that at the Business Healthcare Summit, and I heard it, and it was super. And I have one complaint: they didn't video it. It was so persuasive.
So it was so persuasive. I heard that there was a legislator from Bighorn County in the room that day who immediately went back that night to a debate and was using some Ed's information. So that was good. Yeah. We had a couple other things going on. We're working with MPCA to explore an opportunity to create an APP residency for nurse practitioners and physician assistants. So work still continues there, trying to create those workforce pipelines. The dental health Ramono project, Rocky Mountain Rural Health Network project, concluded earlier this year. And that was an opportunity to cross the medical dental divide and train medical providers on the importance of dental health. And we have also now officially trained successfully about 99.5% of our workforce, not including new employees that have just come on, in de-escalation skills through Crisis Prevention International, or CPI. Aggression against healthcare workers is still a top issue nationally and locally. And so we've given our folks tools in their toolbox to help manage aggressive patient behavior, aggressive client behavior, and de-escalate situations before they blow up. We had an opportunity last week to talk to the Breakfast Exchange Club. We educated them on our Kid Connect programs, public health and family health services, and made an ask to them for some support. We continue to be an active partner in Substance Abuse Connect Coalition and the Suicide Prevention Coalition. And so 988 and 211 are two direct sources of information and outreach. Call 988 if you are in a mental health crisis, and they will connect you to help. 211 will get you additional resources and information in the community with service providers. And so those two 24/7 hotlines are completely free. We had a great opportunity to head out in September to Walmart. We participated in Baby Days. We told several people in Medicaid benefits. So that was a great opportunity to outreach. And then as a result, we're going to receive about half of this now, but we'll get some donated supplies such as baby shampoo, lotion, and other things, prenatal vitamins as a result of participating in that, so that we're able to get those out in the community and share those with families who come to us for care. We're participating in a couple trick or treats and other events across the community. So feel free to attend the Collective Impact Series out at the United Way next month. And for our aging population, the Montana Area on Aging and Go Grandparent, they're both teaming up to provide free rides and grocery deliveries now to older adults in Fergus and Yellowstone County. So if you know anybody that needs transportation or some grocery deliveries or prescription drug deliveries, feel free to share that information. We're going to continue to offer free blood lead testing for children. We know that there is no such thing as a safe blood lead level, and lead in childhood leads to behavioral issues, developmental issues, poor performance in school. And so we're trying to get a baseline and figure out how big of a problem lead be in this community. And this is not a dig on our blossoming, blooming airport, but it's a fact that piston-driven aircraft still operate on leaded gas. Avgas is still leaded, and so there have been studies done across the country that exposure to those emissions can lead to elevated lead levels and can cause issues in communities that are in close proximity to a civil aviation airport, which we happen to have.
John, do we have any data, preliminary or otherwise, on what we found in blood levels in children?
Yeah, we track, so public health tracks that. It's actually Lead Poisoning Prevention Week this week. That was part of the reason why they held that event yesterday. We track, the elevated lead levels are all reportable. We have not been seeing a huge spike in the lead levels that we have in children in our community. I think the big challenge, one of the challenges though, is we as a state have some of the lowest lead screening rates in the country. So it's recommended that all children get screened for lead, either with a lead test or with screening questions. And we're just not as good at doing that. So there's actually a lot of education. We're doing an education campaign out to providers as well with this lead poisoning prevention grant to try and increase, appropriate screening. So the short answer is no, we haven't seen, increased lead levels here, but we might not be, but we're not screening everyone as we should be. So we don't know.
Targeting, for example, areas in the city that might have older homes with lead-based paints.
So that should be part of routine pediatric child care business. Is standard screening at certain ages. So usually 12 months and 24 months is when we should be doing routine blood level screening.
The city has a program for eliminating lead pipes, right? And I don't know how far along that is, but I think they had it right in their schedule. They were.
Part of what we also really haven't had in our community is when we do have elevated lead levels, a team to go out and really comprehensively evaluate what's causing that lead level, those elevated lead levels. And so that's part of what is being developed too, is sort of that response team of how do we respond when we're seeing elevated lead levels to make sure, we provide information, but we don't necessarily have a team that like goes out and measures the lead and, in the water in the house or, does lead level testing in the soil around that house. And that's part of what we're developing.
For several years, the city was replacing water pipes in the north elevation area, and I think there were some lead pipes there that were being replaced or at the option of the owner in some cases.
So lead screening is routine part of pediatric care.
Yes. We miss it oftentimes. It's interesting, when I came here, I don't know about you, Dr. Chappie, but when I came here, we did, lead levels was a huge issue in Boston, where I came from, right? We actually, I treated a number of kids with elevated lead levels. But then when I came here, sort of the message I got was like, oh, it's not really a problem here, and so there just wasn't that same sort of, compliance with testing. The other thing that happens is that a lot of kids miss, so depending on how, and this is part of what we're educating the groups, part of how lead level gets done or remembered is if you're using templates with decision support in your EMR. And so if I pull forward a 12-month-old template, then it has it in there, oh, I need to do lead screening. But if a child misses that 12-month visit and just comes in at 15 months, then it might not be pulled in as part of that template. So we're trying to help practices to
There was
look at all
also
of those.
a problem, because I know that when I was in practice, we did have as a routine, we do a lead level at a year. I think that's 2 years.
Yeah.
And then there was an issue with either the reagents that you couldn't get them for like a year or two.
Yeah.
Yes.
That
So
happened as well.
I don't know if that's been resolved or
I think
not.
it's been resolved now.
So that is standard, is to do a lead level. That is.
I know in the school district, they were testing all the water faucets for lead. The solution was to identify which ones you can drink out of them.
Yeah.
So,
Yeah, so if your house was built before 1960, there's a high chance that it has a service line, the line from the house to the water main that is leaded. And so that was the city's initiative to a couple of years ago to go out and see, check your service lines, make sure they're not, because there's money coming into the state and the city for replacement of those pipes. All right. Michael.
No,
Oh,
thank
good. Yeah. So the public health officer update, flu remains low right now. Yes, Mike.
before we get into the health
Sure.
officer thing, just a quick clarification. We got some negative people promoting gun lots.
Yes.
Okay,
Yes.
that's enough. A quick comment. As much as we try to please everybody and serve everybody, I guess sometimes we don't please a small percentage of the population. Nonetheless, this organization, this board, and RiverStone stands for something, and I'm proud of the fact that we're, as a gun owner, I'm proud of the fact that we stand up for something and promote something that's beneficial for children in the community. Not ashamed of it bit.
No, not at all. No, I appreciate it, Michael. They're just like any issue. There's going to be information and things that are shared. There's a very old from the early 2000s or even 1990s NRA talking point that physicians are trying to take people's guns away, and it's not. It's a public health issue, and we're trying to solve a public health problem with unnecessary deaths and injuries.
I was just gonna say, we're not telling people they have to have them or anything else.
No.
They're available for free.
Exactly.
And I took advantage of that. I've got grandkids now in the house. It's a little bit different game. So I appreciate, I got those. It's kind of pushed it on. So yeah, it's interesting the perspective that people take on giving something away free to help keep their house safe.
For sure.
And I didn't have to take them.
For sure.
I mean, it wasn't forced on me.
No,
But it-
no, absolutely. No, and I love how we can just absolutely celebrate the economic benefit of having a new corporation come to Montana from another state. And, you know, their whole technology is based on safe storage.
Right.
And that is a win for our community. But when public health opens their mouth and says, that is a win for our community, that's a really good thing, it's taken the wrong way.
And that even cost $500.
Right.
For God's sake.
Right. So, yeah. Anyway, it'll continue to be a never ending story. So, talking about flu, fortunately, there isn't much to talk about. We've only had a couple positive cases, less than 1%, less than half of 1%. And so it continues to be a good early flu season, and hopefully it stays that way. You know, was talking earlier about, you know, the Southern Hemisphere providing good information on this year's flu vaccine. Just saw a report last week and earlier again this week that it may not be as high of a match as we thought it was. And so we'll continue to watch flu as it comes around. COVID-19 continues to decrease. I separated this out just for 24 and 23 data. The red line is 24. And so you can see we've just seen about 14,500 confirmed COVID cases across the state. Only 950 of those, or just over 6%, were hospitalized, with only 58 reported deaths, so less than 0.5% there. So COVID continues to evolve and do what it does, trying not to kill its host. We have seen several pertussis, whooping cough exposures across Montana, and we've also seen a few here in Yellowstone County. 45 cases of pertussis have now been reported in Montana in 2024, with 28 of those occurring within the past few months. And it has occurred across 14 different Montana counties with outbreaks up there.
So are there any studies on prevalence of pertussis compared with vaccination rates?
The prevalence of pertussis has gone up exponentially as vaccination rates have decreased.
So has someone publicized that?
Much, yes, yes.
World Health Organization has a whole page on what happens to disease rates when vaccine rates drop. If you want to go take a look at it.
We are unfortunately in the world today, in this post-COVID climate, that we are going to see more cases of pertussis and whooping cough, more cases of varicella and chickenpox, more cases of measles, because vaccination rates continue to decline. And so I've included some information there on pertussis about what it is and why we want to avoid it. The best way to avoid pertussis is to make sure that you and your family are updated on your Tdap vaccination. And please stay home if you're sick. No matter what you have, just stay home if you're sick. The final public health update that I wasn't able to throw in our report last week, we have seen a total of 13 E. coli cases as a result of the national or regional outbreak related to McDonald's quarter pounders. And so if you try to get a quarter pounder locally, fortunately you weren't able to earlier this week. The stores have shifted their supplies. So we had an earlier E. coli bump, and we were wondering, what is this related to? Well, now we know. We know that it's tied to this reported McDonald's issue. And so we're working with those folks. 5 of the 9 cases that we have here in Yellowstone County were matched genetically to the sequence within the national McDonald's outbreak. And so we know that it's tied to that. Any questions or concerns? Michael?
Told myself I'd be quiet, but. A question first. Do we have any plans to try to impress the community with the importance of childhood vaccinations? Do we have anything ongoing?
We do. We
Okay.
have a vaccination campaign in development. We have some of the COVID funding that Shannon talks about, as we have restricted funds available for the organization. And some of those we're going to try to push into not just childhood vaccinations, but the importance of COVID and flu vaccines, the importance of older adult vaccines for shingles prevention, RSV prevention, and the like. So we're going to do a mass vax campaign as it relates to all things public health and just your general health.
Perfect.
We also know that, we know from even the data that we've done locally on immunization uptake, that one of the most influential factors in people getting vaccinated is their primary care provider. And so we have also done education, most recently at the end of September, around the pertussis issue out to all of we sent out a health advisory network alert that talked about the importance of encouraging vaccination in patients. And so we're trying to also impress upon the primary care providers in town and the urgent care providers, because, a lot of people are getting there, they don't have primary care providers and they're going into urgent care to get care. So.
And one last comment, because John, you brought it up and made me think about it. The world thinks qualitatively. So when people hear the vaccine isn't the perfect influenza, isn't the perfect match, it's all or none. It's no good. So why get vaccinated? In fact, you get vaccinated and there's significant protection that may not be as much protection. In the world of science, we have to think quantitatively. And so somehow when we do these campaigns, we got to let people know that there are benefits. It's not all or none. I don't know how you do that in the campaign. I can only sit here and get irritated about it.
For sure. For sure. Thanks for sharing your information. I think everybody's familiar with the concept of herd immunity now.
Well, don't get me started on that.
Michael, it's like wearing your seatbelt. It doesn't guarantee you survive the crash. It sure increases the chances.
Well,
It's a great way.
thank you for that.
Yeah.
I never used that one with my students, but I don't have students anymore.
Is the recently Ninth Circuit decision where the mandated vaccination going to require us to revise our recently revised policy?
We're looking at their revisions to our revisions, and we're revising them with legal counsel. And so the short answer is yes, it'll impact us. We're figuring out how and what we need to do to effectively comply with 702 and keep our staff and patients safe. That's all I have. Yeah.
Very good. Megan, you're up.
All right, my report is in the packet. I think we kind of touched on a lot of the things already. We have started recruitment for the new residency class, so that's always exciting. We have around 130 interviews that are already scheduled. They'll be starting in November, and so that's always an exciting time to start. It's like an endless cycle. We have like a moment of pause, and then we start the process again. So it's kind of exciting that we're getting those scheduled. We're still working, increasing medical encounters. I didn't include graphs this month because we're sort of in between shifting from getting data from one data system from another. And I'm still trying to figure out the best way to report these numbers out as far as medical encounters to the group. So I didn't include it in this packet, but I will the next time. In general, we have been seeing a continued trend up. We are continuing to struggle right now with staff coverage for providers, and we have intermittently had to cancel provider clinics or not have providers in clinic because we don't have enough staff, but we are working on that issue pretty intensively to get that restaffed up.
So while you try and increase the number of visits, how do you guarantee quality stays the same?
Yeah, I think that's a great question. So we haven't changed we've done a lot of different things to increase medical encounters. We have not shortened the duration of the visit. A lot of what we are trying to do is to make sure that we are consistently staffed with providers and clinics. So one of the challenges of being a teaching health center and having 60 different medical providers that all have various part-time statuses is that it's hard to have a consistent number of providers in clinics. So our resident schedules, especially being a community residency program where we rely on community preceptors. So when we have a resident who's working with cardiology, we kind of are dictated to when they want the resident there rather than us telling them this is when the resident's available. And so ultimately what that affects is when we can put, those residents in clinic. So we have a lot of fluctuation. So we've been working really intensively with the residency program to try and even out those peaks and valleys of having providers in clinic. And then, really working on our no-show rates and how to fill, make sure that our schedules are all filled to capacity. We know we're going to have a higher no-show rate as a community health center. We have lots of patients who have barriers to getting in for care. And so really trying to manage, a lot of most practices in town, if you have a patient that no shows 3 times to a visit, they just won't schedule that patient again. It's 3 strikes and you're out and you're not able to be rescheduled. We don't have policies like that because we really recognize that we're the safety net. And there are lots of reasons why people miss appointments. Unfortunately, that makes us carry a higher no-show rate than a lot of other primary care practices. So we're doing things like that to try and optimize patient encounters, not shortening the duration.
And you send people reminders about their appointment?
We do. We send people reminders. Again, we're working part of I talk about lower down in the page, sort of our IT optimization and our EMR optimization. That is a huge piece of increasing our workflow efficiency. And so we're working with IT and with our EMR to look at ways that we're communicating with patients and try and optimize that in a way that meets those patients' needs. We also, one of the projects that we would like to do, which requires many steps before we can get there, is change the way that we do our scheduling so that the patient is told, your appointment time starts at 8 a.m., but they're not actually scheduled. They're not on the provider schedule until 8:20. And there's not a way. So we have messaging that says, come minutes before your appointment, but no one listens to that. And so when you have an appointment time that says 8, your arrival time is 8 a.m., that works much better. We currently can't do that in our system. And so we are trying to make the changes that we need to make so that we can be able to do that. So that's sort of our status with our medical encounters. We're also working, more strategically than we have in the past to really understand sort of our different service lines and what our service lines, so behavioral health, for example, how many encounters are behavioral health providers generating and billing for, and how many encounters do we have to offset the cost of the providers and the support they need to be able to provide the care. And so I think we are getting more sophisticated in the way we sort of look at some of those operation metrics. We still have room to grow and develop and improve for sure on how we are accurately measuring operation metrics, but I think that we have made some significant improvement there. So that's sort of the clinic update. We talked about the pertussis, we talked about lead poisoning, the Child Advocacy Center. We got our final determination back from our accreditation that shows that we're in the pending status of accreditation, which we knew because we don't have medical up and running quite yet. We did receive, so the Attorney General, some of you were maybe part of that press conference, did a press conference here last month to announce that they were giving $10,000 to all of the accredited CACs. Ours is one of the accredited CACs in the state. And he also committed that the $3.5 million that was that settlement money from the talc powder case was going to go to child advocacy centers and child abuse. We don't know how that money, they haven't, they're working on how they're going to distribute that money. But hopefully we'll be able to get more. We do have a big need in our state, in this community, in creating like a child abuse network of providers who are experts. We do not have a single fellowship trained child abuse pediatrician in the state. And so that means that our child abuse evaluations and support comes from other providers like myself, and other people who have done additional training in that area but are not fellowship trained. And we really need to find a way to better support our smaller, our more rural communities where we know we are having cases of child abuse that are going undetected because they don't have any consultative services available. So there's sort of some talk about that. And I think that's it.
Any questions for Megan? Jim, you're up.
Great. Morning. I'm gonna start with Shanna's memo. I'm gonna go down to those bullet points, which I think is just a great way of laying out the most significant financial issue. Since late winter, early spring of 2020, we have paid a lot of attention. That's when the virus got here, interrupted patient flow, which drives a lot of the cash with the organization. Services consume cash and they cause remittance from payment for those services. A lot of that was interrupted, so we didn't know how we were going to keep the doors open. We have paid a lot of attention to cash ever since. We are still paying attention to it. Her first bullet point says cash was 7.9 million. At the end of August, it decreased 700 grand. So, fellow board members, when I want to see the cash, where do I go? Go to the first line on the balance sheet. And it says cash, I hope. Where is it? Operating cash. Okay. And it says it was 7.9 million. I take the operating cash and add on deposit, the county at 7,871,000. Said it decreased about 700 grand. If I want to understand why it decreased. In these statements, I would go to cash flow report. Let's see what went in and out. And it's the third page of the statements, statement of cash flows, August 2024 financial report, statement of cash flows. The top little block there is what's coming in from operations. The patient receipts, 2.7 million. Grant receipts, contract receipts, tax receipts, other, $4.5 million came in. And what went out? Salaries, purchases, and other. Salaries is the biggest. The purchases would be paying for supplies, rent, yada, yada. Going out the door was 5.2. So we went down 682,000. Just from that, we bought some equipment, 43,000. In total, we're down 700 grand. Okay. When I looked at that, I said, all right, we got 3.4 million in payroll. Went for salaries and benefits. So I went and I grabbed the income statement. Statement of revenues and expenditures. Because that's going to tell me what our biggest expense line, salaries and benefits are in the 30-day period. I went down to the first line in the second block. The first block is revenue coming in from operations. Second block is expenses. And there is that same 2.7 million. Wait a minute. That's not the same number. It's 2.7 million here. And the cash flow is 3.4. Uh-oh. What does that mean? Remember, payroll every 2 weeks. Right? 52 weeks in a year. 26 payrolls in a year. Spread over 12 months. Twice a year, make payroll 3 times. Fiscal 25, one of those months is August. Okay. So that's the driver of why cash went down 700 or 800 grand this month. Had to make 3 payrolls. I want to understand what happened in operations. Accrual basis, not cash basis. Accrual basis. I'm going to go to that P&L. I look down that revenue block. Got to the total operating revenue of 5.2 million against the budget of 5.3. A variance of 187 grand. After the challenges of the last couple of years, I said, damn good work to the finance folks. Went down the expenses and they're up 365,000. And I looked at the finance staff. I said, damn good work. They're 2 months into the year and nothing hellacious has jumped out from that budget that was so darn difficult to put together. Net operating revenue, what is operations profitable or not? For the month, it was profitable, 320,000 for year to date, 668,000. With me, 2/3 of the way down the page, net operating revenue. That's what the blood and guts of RiverStone produced financially in that. Year to date, we did 668,000. After the last few years, that deserves a rousing hallelujah from everybody on the board. Probably don't want to do it. Hallelujah. All right.
Hey, so Jim, if we sent the finance group congratulations on behalf of the board.
Not that I'm aware of.
Shall we do
And
that?
I think that'd be a great idea, Coach. Non-operating stuff. Unless somebody else. Very bottom line, net revenue over expenses, positive and ahead of budget. It's not dramatically ahead of budget. 2 months don't a year make. Don't either. I can remember John Hedge used to always tease Shelley and said, well, we can go multiply that year-to-date number by 6 then. Send it in and come back next year and everything will be fine. And that's not the way it works. Nobody knows what's going to happen in clinic today. Nobody knows how many patients are going to present, what their complaints will be, yada, 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 and coverage they will have, et cetera. A long way to go. The balance sheet is, I shouldn't say that. Balance sheet is tight. We are not rich. We are in healthcare facilities, are not wealthy facilities. It's not like Microsoft. And we are among the poorer of the providers because of our clientele and our business. And we just went through the pandemic and we're in worse shape after the pandemic than we were before the pandemic. So we got a lot of stairs to do to get out of the hole. But I'm as optimistic today as I have been since February of 2020. So I think it's a better picture than I've seen in 3 or 4 years. I like running against his budget. I like what I'm seeing in clinic. Results we're seeing, the patient volumes. We got a long way to go. All right, we go down to the second bullet on Shanna's memo. I remember we're always talking about stints. When the Fed started coughing up money and sending it to us to get through the pandemic, it went into deferred revenue. We've been watching that since whenever, 2020, since we got the first money out of the Fed. There's still about $1.6 million in COVID funds there. Our organization is creatively looking for better ways to use it. One's a mobile clinic that's they're working on hard right now. And that's about the only other thing I want to say. Any questions about the statements of the memo?
Nice job summarizing, Jim. Thank you.
Anything I forgot, Sheena? Okay, all right.
Okay, Lionel.
Well, first of all, I feel good. Thank you, sir.
That's good job, Lionel.
Do we have to accept anything?
Mike,
Oh, yeah.
We need some.
oh, thank you. We need to accept the October 17th meeting notes.
So moved. Second.
All in favor? Anyone opposed? Next, we need to accept the August financial statements.
So
Second.
All in favor?
I,
Anyone opposed? And I even highlighted that in yellow and still missed it. Lionel, you're up.
All right, well, this is a report on the safety quality committee. We had actually very informative reports. The first had to do from our purchasing department. We became aware that our methodology for purchasing was or has been in the past varied. Anything from asking for something on a napkin, something filling a form. And so there's a lot of work been done to standardize that process. And we also learned that we haven't always checked to make sure that a provider of service wasn't an excluded provider. That's been fixed too. So there are a number of things that they looked at, trying to bring everything up into a big place. So we also had a report from Shelley Ontiveros, our smiling person at the front desk here in the Low Anderson building. And some of the reasons for our having to wear name tags now having to, get buzzed in and all. In the past, had people wandering around and not knowing who they are. We've had weapons being brought into this building. And we've even had a wall punched by somebody at some point. So that hopefully won't happen again. So again, that's been fixed. And then we had a report from financial services about, we had recently 3 audits, site visits, which all went well. Took a tremendous amount of work. And one of the things that came out of that is that our software, our financial software is old. I think it's not being supported anymore. And we were just given a heads up that we're going to need to replace that at some point, which means that some of that good financial basis that we're on now is going to be spent on some financial software at some point in the future. Maybe not the too distant future. We talked a little bit about provider training. So when a new provider comes in, residents or non-residents, they need to be trained on the systems and on coding. And there's a process by which provider that's provided and also how it's monitored. So the provider that's not coding adequately, that individual receives a bit of counseling on how to improve their performance. So overall, we learned quite a bit. And our financial services people are, I think, doing a good job unless the wool has been pulled over our eyes, which I don't think that's.
Cynic. Any questions for Lionel? Yeah, you're up.
Well, my name's not here. So we did not have a meeting, but there is supposed to be information presented to you by John Doerr and Melissa Henderson. Not by John Doerr, but.
It'll actually be John Forte and Eric.
Okay, well, there you go. So I hand it off.
Thank you, Deanne. And before Eric gets started, I'll let him go first. I just wanted to update the board and the group that the bill tracker on the Montana legislative site has gone live. And I've been pulling proposed bills and things that are out there in draft form. And there are a total right now, as of yesterday, total of 70 bills. Some of them are duplicates, but a total of 70 bills just having to do with health and human services. So all different issues that will affect us one way or another from either a public health perspective or a healthcare delivery perspective. So we're going to begin tracking those. We'll begin bringing updates to our policy development committee so that we can hopefully educate and inform the legislators writing them.
So before Eric gets going, we need to accept the October 1st meeting notes of the quality committee.
So move.
All in favor? Anyone opposed? Okay, Eric.
Right. So this is the next hit in the parade of the legislative priorities, education sessions for you all. So we've got a today. I'm going to be covering the topics of immunizations, and so we've talked a lot about that. I'm also going to be talking about funding for public health infrastructure. And then John's going to talk with you all about community health center funding stability and issues related to that. So let's start with the IMS because it's come up a couple times today already. So here's basic information for you all. I'm not going to spend a whole lot of time on this because you all can read, but they're just pretty common sense why are immunizations important for the layperson on the street? There's not a lot of technical jargon in here. It's mostly focusing on issues related to helping to keep your own family healthy and safe, helping to keep those around you healthy and safe. That it prevents diseases such as measles, whooping cough, COVID-19, and others that are still floating around out there. That as much as we here in the US like to think that we live in an impermeable bubble sometimes, people with these illnesses come into the US and bring them with them. I think if there's one thing that COVID taught us, amongst the many things it taught us, is that in this world economy day and age, diseases fly around the world really fast right now. And so thinking that you're safe being not vaccinated just because you are kind of in a bubble of people around you that might be is a misconception. The World Health Organization, I didn't put this on here because this was pre-done. But if you want to write it down, World Health Organization current estimates of lives saved per year from vaccines is 3.5 to 5 million lives saved per year from people who would have otherwise died from a vaccine preventable illness had they not been vaccinated. And to get to John Doerr's question from earlier, I was doing some research on this at 6 o'clock in the morning, so I happened to have it right on the World Health Organization Myths and Misconceptions page. What happens if countries don't immunize against disease? So we have some history in this. 3 countries, the UK, Sweden, and Japan, cut back the use of pertussis vaccine because of fear about the vaccine. The effect was dramatic and immediate. In the United Kingdom, a drop in pertussis vaccination in 1974 was followed by an epidemic of more than 100,000 cases of pertussis and 36 deaths by 1978. In Japan, at around the same time, a drop in vaccination rates from 70% to 20 to 40% led to a jump in pertussis from 393 cases and no deaths in 1974 to 13,000 cases and 41 deaths in 1979. In Sweden, the annual incident rate of pertussis per 1,000 children of 0 to 6 years of age increased from 700 cases in 1981 to 3,200 cases in 1985. There were also, and then it goes on to talk about some epidemics of diphtheria that happened in Russia as late as the 90s that had spillover into the surrounding countries in Europe. So,
Eric, did the countries get smart?
yeah, they did. So anyway, real life experience of what happens when vaccine rates start to drop in other industrialized countries around the world. So that's some information, some talking points for you all on vaccines. The next one here for you all. So this one's a little more kind of nebulous. And what we're talking about here is support and continuation of financial support for core public health functions. So what are core public health functions the way we're talking about them? So communicable disease control. And so in our organization, communicable disease control is what we do with all the list of preventable condition or reportable conditions. So when doctors identify someone who has a reportable condition, they send it to us, we investigate it, we figure out how to stop it from spreading if we can. We do an analysis of what maybe caused the outbreak or the person to get it in the first place to try and prevent more people from getting it. Our communicable disease control program also includes our immunizations program. So our immunizations program is directly providing people with immunizations. through our immunizations clinic, but also working with community agencies that are caregivers of elderly folks or children to help do education broadly in the community and education with service providers who are caring for people about the proper vaccines to be getting in certain settings, stuff like that. Chronic disease and injury prevention is at a population level. That's a lot of education work that we do, a lot of lifestyle work, promoting healthy lifestyles, promoting access to healthy foods, eliminating food deserts. A lot of our chronic conditions in this country can be partially, if not fully, controlled through better diet, exercise, lifestyle change kinds of things. So we're talking about diabetes and hypertension, obesity, those kinds of things. Environmental public health. So that's our registered sanitarians who are doing inspections of restaurants, grocery stores, any gas station that sells food, hotels, public swimming and hot tubs. What am I leaving out? I'm sure I'm leaving a lot out that they do. Daycares, they inspect daycares to make sure that they're staying up on their safety standards. Congregate living facilities, they look at to make sure that they're staying up on their safety standards. All of that stuff kind of falls underneath the environmental health bucket, as well as working in partnership with the state to do air quality monitoring. So when it gets super smoky out there, we're looking at the air quality and sending out alerts when needed if the air is getting unhealthy for certain populations in our community. Maternal, child, and family health. So those are what we kind of refer to as our family health or home visiting programs. That's our nurse family partnership, parents as teachers, our foster care programs, things like that, where we are trying to work with parents in our community for healthy starts for kids. And then access to and linkage with clinical care. So one of public health's primary responsibilities is to look at areas where there are gaps in access to basic health services for people in the community and figure out how to fill those gaps. Right now, a lot of that is being focused around mental health, substance abuse, some of the really urgent emergent issues that we're having in our community around those, behavioral health, mental health, psychiatry. It extends further than that. We still have issues with basic primary care access. That's why as a public health agency, it makes a lot of sense for us to be a CHC as well. We have huge challenges with getting kids, even well resourced kids and families into ancillary services like therapy services, speech, OT, that kind of stuff. Megan talks about that all the time, about how hard it is to get kids into those services in our area right now. So public health steps in to try and create the systems broad systems that facilitate access to those. So if you flip over onto the back side of that page, so what's the funding gap? Well, the funding gap between what the federal government and the state government gets us is what we fund with our local public health tax dollars. And so on the right side of this back page, you can see in each of those buckets how much of those services are funded through mill levy, which is our local public health mill levy. So in other words, if we were relying as a public health agency solely on state and federal funding of public health infrastructure, we would have, if you would have to go out and take out all that mill levy money, and that's what we would be left with to provide public health services to Yellowstone County. In public health, and Shanna step in here, but I think a reasonable estimate, if you want to think about this in terms of boots on the ground, is that every one of our public health positions is probably in the ballpark, fully loaded, of about $75,000 to $100,000 a year. So when we say in communicable disease, you know, $500,000 of their funding is our local tax dollars. By local, I mean our property tax dollars, not funding from the federal or state government to support the work that they mandate that we do at the local level. That would equate to probably 5 to 7 positions fewer than we have now to do that work. So that's kind of the gap between the money we get from the people who are telling us, thou shalt do this, and what it takes for us to serve a population of our size at the local level. Does that kind of make sense? And then to take a deeper dive on that, this one's going to be coming up in the legislative session. The last page I put here is what the Montana Public Health Association, also known as Confluence, is putting forth as one of their big priorities for the legislature, our state legislature, this upcoming session, is evaluating the fee structure at the state level. And so, you know, this graph here shows all the fees for things that the state says through law we as a local health department have to do, and how much they allow us to charge for that thing that we have to do in order to support the services. And if you look back at this graph right here, and all the places our mill levy goes, one of our highest allocations of our mill levy is into environmental health. So nearly $1 million of our mill levy every year goes into supplanting what the state tells us we have to do at the local level, but doesn't allow us to charge in fees enough to cover the cost of doing. Does that make sense? So this is one of MPHA's primary priorities for this year. To give you a really good example, we were just talking about this yesterday. When we go out and do a daycare inspection with our environmental health person, 2 people have to go. Brenda goes because she goes out and looks at the immunization records. And then a sanitarian goes and they're looking at all the cleaning standards and the health and safety standards, and are they being followed by a daycare? The state gives us $25. You get $25 to do that. So, I mean, that doesn't even hardly cover the cost of the drive to get them there these days, right? For those of you who are doing business. That's the 2 that I'm going to cover on vaccines and then funding for basic public health infrastructure. Any questions from?
Couple questions. Sheena, when we get into this situation of doing daycare inspections, food service inspections, is there anything coming back in those county tax dollars from the licensing fees to reimburse us for those costs?
From the county tax dollars? No.
Yeah. Okay. All right. Then the second question, Eric, when I go to the immunization flyers like this, when I think through immunization and the challenge, I'm guessing that the education needs to occur is at the parent level.
Mm-hmm.
So do we get this to the kids through the schools, to take home to their parents, to do any of those things? How do we try to educate the parents?
So here's the thing. We did a survey with some of our vaccine money, some of our COVID vaccine money. We did a survey with a statistically significant size, sample size of Yellowstone County. And the number one influencer of a parent's decision-making about whether to vaccinate their kid is their relationship with their primary care provider.
Okay.
And so a lot of our work is working with the primary care providers in our community to talk with them about the importance of their relationship with parents, and how influential they can be in the decision-making process. We do talk directly to parents. We go out to community events to get these kinds of things. We drop them off at daycares when we go for them to distribute. All that stuff, but
Yeah, and we did send out, John, didn't we send out at the beginning of the year through at least school district 2, that information packet on vaccination with a letter that we had created through the YMAG group, the Yellowstone Medical Advisory Group. We had created a letter encouraging vaccination that was signed by the CMOs of all of the healthcare systems. And we sent that out, the schools sent that out through their channels. So it was coming from medical providers, but we
Okay.
sent it out through them.
And so I'm sure the clinic is plugged into this and communicates to parents, yeah.
So Megan, if we sent that to church groups too,
No, but that might be a good idea if they would.
yeah, it's interesting. Surprisingly, this kind of surprised me, but spiritual leaders were not, they were far down on the list of influencers in terms of whether to vaccinate your children. They were not viewed by the people who responded to our survey as a decision support, decision helper in that particular case.
How about social media like Instagram?
That was higher.
A lot of the young parents get their information from groups of parents, and that's not really valid information.
It was higher on the list. It wasn't super high, but it was kind of in there around like a little bit below like advice from friends and family kind of. So, or unless, are you remember?
I don't remember exactly where it fell on the survey, but I think I think the survey can help to influence what we know are the most effective ways to communicate. But the reality is we need to educate through all of those channels, right? Like the survey helps to reaffirm that conversation with primary care providers is really critical, but there are lots of patients who don't come into primary. So the reality is what has been shown to be most effective in people getting vaccinated are requirements that you get vaccinated prior to school. Because there are lots of kids in our state that don't have primary care, that don't go in for well child care after they hit like age 2. Like they kind of drop off on that, coming in for well child care. And so one of the things that gets people back in to see their providers is the fact that they need to get shots done before they enter, kindergarten. And so we see a big gap, up to age 2, we see kids coming in. Then we see a gap in kids coming in for their 3-year-olds, sometimes 4-year-old, but we get those kids before they go into kindergarten. And so vaccine requirements work. I know we don't like to require people to do things, but this is a public health effort that we know has had vaccinations out of all of the medical interventions in the last couple centuries. Besides antibiotics, the vaccination is the most influential medical intervention that has improved mortality and morbidity in the world. And so All right, I'm off my soapbox.
Oh,
There's a great, on the World Health Organization, there's actually, I just did a lecture with the residents on how to have motivational interview conversations with parents who have, or people who have vaccine hesitancy. And so I was, on the World Health Organization, and there's a great site on there as well about vaccination history and where, like the history of vaccines, dating back to, some of the, the first, when the first vaccines were created. So anyway, go check it out. That's neat.
And there are some parents that despite all of this, still.
Right.
Do you have an estimate, Eric, on the amount of additional revenue that was brought in if the changes were adopted as proposed? I'm sure it would make up the gap, but
No, but I mean, you can see what they're recommending is 100 at the opted in. There are two options here. One is an across the board, like 115% increase over current rates. The other is a more targeted approach to it. So like, I don't think, Shanna, we've gone through and like done an analysis of it to see how much additional money if we bring in. Probably not going to be $900,000. In fact, I know it's not going to be $900,000.
But it's not the benefit, it's not about revenue to public health. It's about covering the costs
Yeah.
of our sanitarians and our environmental health staff and lessening the threat to the public. And so one, you're spending less of the public's hard-earned property tax money. So you're saving property tax dollars.
Yeah.
And then you're increasing health and safety by allowing us to hire additional sanitarians to close the gap into what our capacity is and how Montana's grown over the past decade. There is a gap between all of the restaurants, establishments, hotels, et cetera, that have come into our state and what we're able to inspect annually.
Yeah.
And so with these fee changes, it only allows us to inspect more of those, close that gap, and create a healthier space out there. So,
yeah.
Thank you, Eric.
Yep.
I provided you with a handout on the economic benefit and impact of Montana's community health centers. Montana's community health centers, which there are 11, serve 1 in 10 Montanans and create incredible economic value into the community. Across the country, there are over 1,400 community health centers. Serving thousands of communities at 15,000 different clinic locations in every state and U.S. territory. Community health centers cared for 1 in 11 Americans last year, including 9 million children, 400,000 veterans, 1 in 7 rural Americans, and employ over 285,000 people, generating almost $85 billion in economic output and more than $37 billion in labor income across the United States. So right now, our health centers are facing incredible uncertainty around the November elections, around state legislative sessions, and what is going to happen so that we can have secure and sustainable health center funding to meet the needs across the United States and here locally. So I wanted to share a couple slides from the National Association of Community Health Centers and just talk real briefly about our workforce needs and our funding needs as we enter into 2025. So there's a loss of COVID dollars, there's Medicaid redeterminations, rising uninsured rates, inflation, threats to the 340B program, and a lack of comprehensive primary care across the nation. We know we have workforce issues, pay inequities, burnout issues and turnover across the country. And so there's a lot of challenges out there. Congress has certainly not made it any better. We have had stable discretionary funding to the tune of $1.8 billion. Fortunately, we've had increases in community health center funding over that same period of time, but there is a dramatic shortfall and a gap between what our costs are to deliver the care and what we continue to receive within the health center fund from Congress. Inflationary costs have certainly expanded, and workforce cost has also ballooned. So again, this is all national data. With uninsured care, it's estimated right now that 100 million Americans across the country lack a primary care provider. At that same time, our cost per patient in community health centers has continued to increase. The number of uninsured patients has continued to increase. And we continue to see a gap between our average 5-year growth in costs and the average 5-year growth in community health center grants that we have been receiving from Congress. So that uninsured cost has risen from about $8.2 billion nationally in 2023 to over $11 billion in 2025. A lot of that has to do with Medicaid redeterminations and things that have happened across the country. But a lot of that is also inflationary. So if we look at the difference, right now, if all things stayed the same, it'd be about a $5 billion shortfall. If we look into what do we need to increase mental health and behavioral health access to substance use treatment, to oral health and dental care, vision screenings and vision care, interpretation services for our patients. So nationally, there's about a $6.14 billion need to meet the needs of the uninsured patients who are out there and new patients that need us. Just a couple months ago, we applied for a new access point grant. HRSA and the National Association are collecting data on those needs. We applied for a new access point in terms of mobile so that we can reach more of our rural communities out there. All in all, it was about a $50 million ask from health centers across the country for need-based ask for new access points for patients. If we take a look at workforce needs and workforce pay equity, you can see at the very top, the greatest pay disparity across the country in our community health centers is for family medicine. Family medicine is about a $214 million shortfall. And we know locally it's right close to that 11% below the industry standard of what we can afford to pay our family medicine providers versus what others across the community can.
John, is that because there aren't enough family medicine providers times the average pay to the people?
This is very much just the average pay comparatively to other practitioners. So
Okay.
this is a graph of what community health centers pay nationally compared to competitors.
Yes.
And the Bureau of Labor Statistics. Yes.
Okay.
So we have a pay inequity shortfall in community health centers nationally. And so one of the things we're going to be asking Congress for this year is to help us close that gap.
Yeah.
And so the estimate of that shortfall, if we were about 138 million behind in 2023, that's increased and we're about $165 million behind, or sorry, $4.2 billion behind in community health centers. The data on the bottom has to deal with look-alike facilities. And so National Health Service Corps, proven program that helps us recruit and retain the next generation of health center workers. We have a bipartisan primary care and health workforce act out there on the table. And that would provide $950 million over 3 years nationally to help with our retention and recruitment efforts to get the next generation in here. And as a teaching health center, we also play a strong part in making that shortfall go away. So last year, the Teaching GME Health Center program across the country treated almost 800,000 patients and saw 2,000 new primary care physicians and dentists complete residencies. We are estimated to have a shortage of primary care physicians in this country over 35,000 by 2035. And so partnering with our new health medical schools and other teaching health centers, we create additional residency slots. We need funding for those additional residency slots, and we need sustained funding for those residency slots. So we're asking Congress for additional funding for those, as well as for additional monies for per resident amount, the amount that we get reimbursed per resident that we have on site to help us sustain our teaching health center program. And we're also going to be working with our state legislature this year to work on a sustainable funding bill within Medicaid funding and Medicare funding to help drive additional residency slots here in Montana. Because we know that the data shows medical students don't stay where they went to medical school. Medical residents stay where they did their residency.
Who are you working with on that state level? You know,
There's a couple draft bills out there, but locally, Pennsylvania's working on.
okay, that's the right legislation.
Yeah. And so that's just an overview of, the total needs and ask for workforce and other programs that are out there. The fact is, we're going to need funding. We're going to need support for continuing our work as an effective community health center. And we're going to work with Congress. I'll be going to Washington, D.C., Capitol Hill next March. And the current state is that the House and the Senate Appropriations Committees are proposing that funding stay level to the tune of $1.8 billion nationally. That is going to fall way short and create a gap. And so our new ask nationally, as the National Association of Community Health Centers, is for a minimum of $11 billion to help us expand primary care and adjust for the number of uninsured patients we're seeing, as well as inflationary expenses, with an ultimate ask of about $17.8 billion that would help us provide new and updated comprehensive primary care. That would help us meet unmet mental health and behavioral health needs, substance use disorder needs, oral health, vision, and provide additional enabling services out to our patients across the country, and help us address some of the pay inequity short issues that we face, and provide with the need to close the pay gap. The estimated pay gap out there nationally is over $4 billion. And so we're asking Congress for additional funding there. So altogether, our estimated funding gap and ask totals about $23.5 billion. And our current base that we're receiving is about $6.5 billion from the federal government. And so nationally, we've got about $17 billion to try to negotiate and close the gap on, so that healthcare can be delivered in community health centers across America.
Thank you for the depressing.
we have work to do. Work
Yeah.
to do.
Anyone have questions for John? He has to leave for another meeting, but
Quickly,
Go ahead, Lionel.
what's realistic, how much do you think?
That's what we're trying to figure out right now. I sit on the National Committee for Legislative Affairs for NAC. And they just sent out a survey with a lot of this data. And my biggest point back to them was, we don't know what we don't know. We have to wait until November 6th, maybe November 10th, depending on when we get results, to figure out who's going to lead the federal government and who sits in the House and the Senate. The good news is that health center funding, for the most part, has always been a bipartisan issue. We have, especially in the Senate, our funding asks to appropriations committees have always been signed in a bipartisan fashion by our senators, by both Senator Tester and Senator Davis. They both understand the need and the importance of community health centers in Montana. We have a larger fight in the House, who just doesn't want to fund anything, it seems, in the House of Representatives. So we will continue to fight that fight and work on getting that bipartisan support. I think we're going to end up somewhere below our desired need and ask. The other ask is for another long-term funding package, and long-term meaning 3 to 5 years. That allows us to plan better, to have a strategic plan that we can actually implement, to bring residents on for that 4-year period with certainty. And the 1-year funding cycles and streams where we have to go back and ask for additional funding at the end of every year just creates a lot of uncertainty and a lot of unease across our community health centers. So we're going to continue to work with whomever gets elected and fight the good fight to make sure that our patients are taken care of and we get the appropriate workforce funding we need.
thank you, John.
Thank you.
And we don't have to approve any minutes now. Next, we have the governance committee and the executive committee. I was not here for either of those meetings, so Michael's going to take over.
It'll be brief. The executive committee meeting, we had a brief introduction to a pending legal matter. John and Jenna will decide when that should come to the full board in closed executive session for the board. But up to Jenna this morning, and it's not quite time to bring it to the full board. She's not quite ready. And just in case anyone's concerned, those advanced introductions to the executive committee follows our executive committee chart. So it's within the charter of the executive committee to do that. And we'll get full information from Jenna when it's appropriate. That's all I have for the executive committee.
And we need to accept the September 26th meeting notes.
Move we accept.
Perfect. All in favor? Okay, governance committee.
Governance committee, we spent our entire time on that wonderful thing that you have gotten in your mail regarding assessment, self-assessment and assessment of board operations. We've been working on this for a while. This is a brand new form that you haven't seen before. I can tell, Don, you're excited about it, aren't you? I can tell. But it is, the governance committee considers it important. Brand new form. I can only say, if you haven't filled it out yet, please do so, because we need everybody's opinion on how they're doing. It helps us plan for the future and how board assessment is going.
And we will be discussing this in executive session, and I'm going to post. I actually answered who has it.
In the governance committee.
No, executive committee.
Oh,
I'm going to
okay.
do that at the beginning, so it's not public record.
Yes. That's all I've got. Simple,
So-
quick, easy. I know you weren't expecting that.
No, I want you to post it in public. So
So we need to accept the September 26th meeting notes.
So move.
Second,
All in favor? Anyone opposed? Okay, we will be going into executive committee, discussing governance committee and John Forte's evaluation that Carrie's going to pass out to you.
Oh,
Michael,
no.
Is that through to the end of the meeting, Don, or should we stick around?
that means you guys are gone.
Okay.
You get to go back to real work.
All right. Don't gotta tell me twice.
Oh, good.